Great, thank you. I'll start admitting people.
Good morning, everyone.
Good morning.
To the Harlem Strong Coalition. If you all could kindly add your affiliation and display your names, and also if you would like to turn on your cameras, we'd love to see your beautiful faces. That'd be really great. That we can kind of get to know each other a little bit more. Thank you. And if you need any help adding your affiliation, you can also just add it to the chat and one of us will edit it for you. What you need to do is just go to the three dots in the corner of your icon or your image, and I think that should allow you to change out. And I'll do the same. I actually have not done that yet. You go to rename. Let me rename myself. So I'm going to add CIMH and CUNY.
Victoria, I'm sorry that I can't on my camera because the laptop camera is not functioning, so I would only be able to speak up. I hope that's okay.
That's okay.
I've
Thank you
tried
for letting
some
us
issues with
know.
the laptop. Yeah, thank you.
Great. Well, welcome everybody. We're really excited to be here today with you all, and thank you for everything that you do in the community. It's actually been a quite exciting time for mental health. I don't know if you all know, but the UNGA meeting happened last week, and it was the first time that mental health was actually included in the high level meetings. So there was a political declaration put out that integrated mental health with the NCD agenda. And there was a voting that happened to approve the declaration. This declaration is actually quite important because it sets the priorities for member states, and then oftentimes, it drives the funding and the budget allocation for what they're going to specifically put funds into their mental health agenda or their healthcare agenda. And some of the things that were mentioned as priorities are certainly youth mental health. That was a very big topic. Integrated care, task sharing, system strengthening. Suicide prevention was also very important. Lived experience, incorporating lived experience into our programming, into our policy planning, into service planning, and trying to think of what else we had there. I think those are some of the key topics that were raised, but unfortunately, the United States did not approve the political declaration. So now it's going to move forward, and they're going to, I think, do another round of votes. But yeah, so that this coalition meeting topic this week on youth mental health is actually very timely because it lines up quite nicely with what's happening globally. So next slide, please. So I'm Vicki No. I'm a professor here at the CUNY Graduate School of Public Health and also the director for the Center for Innovation in Mental Health. I lead the Harlem Strong Project, and we partner with the Harlem Congregation for Community Improvement. Dr. Punter, I think, will be on shortly. He's my co-leader in this, and then we also have Deborah Levine, who leads the Harlem Health Initiative. I know some of you might know her. She's sort of the glue that connects all of us. We also have Health First as one of our lead partners. They've been really helpful in terms of helping us think about sustainability and the translation of this model into different ways of financing this work in the future. So Thank you to the coalition and, there are many folks within this project. Can you go to the next slide, please? So we'll start off with some brief introduction about the program for some of you who are newer to the coalition. And we'll be able to dive into youth mental health. We'll get to hear from our esteemed presenters who will share about current research on youth mental health, frontline perspective, parent and caregiver perspective. Then there'll be a breakout discussion that will allow us to kind of, address some of the questions around the applicability and, where the gaps are within our community. There'll be brief presentations from coalition members on youth mental health services, and then we'll end with updates and events. And also feel free to, to share with us any events and anything that you want to share with the coalition. You can also post them on the chat, and we will be putting out a report after the meeting. So we'll share all of those resources so everyone can have those resources. Let's go to the next slide, please. And we have a brief video to share a little bit about what we do at CIMH and a little bit about the progress of Harlem Strong. Much of our work is focused on integrating mental health services into non-mental health settings. So we've got a number of different projects from the work here in Harlem all the way to Vietnam. We work with the city quite a bit in terms of integrating mental health services, and the video will share a little bit about that. Go ahead.
The Center for Innovation in Mental Health is an academic training and research center that promotes the reach and adoption of effective mental health interventions through research, evaluation, training, and policy. CIMH engages in local and global efforts to advance mental health service and research to improve access and quality of mental health care. The Building Resilience in Youth (BRI) program focuses on providing increased mental health support and resources to NYC youth aged 13 to 21. To fulfill its aims, community-based organizations are supported by affiliated mental health partners to enhance mental health literacy, build resilience in youth, and promote community mental wellness. The Jobs Plus Mental Health Integration Program was developed to support employment support providers in NYCHA to address the mental health needs among public housing residents. Jobs Plus' primary goal is to help increase provider capacity to work with members and improve their mental health and wellness through technical assistance, training, and peer support via a learning collaborative. The Harlem Strong Mental Health Coalition Project is a collaborative effort led by the CUNY Graduate School of Public Health and Health Policy, in partnership with Harlem Congregations for Community Improvement and Health First. Harlem Strong aims to transform mental health services in Greater Harlem, New York City, by building capacity in mental health task sharing in gateway settings like housing and primary care, and other community-accessible sites to support mental health integration and connections to a range of community services. Our research study will use a randomized controlled trial design to evaluate the effectiveness and implementation of the full multi-sectoral community collaborative model to better understand the impact on consumer access to services and outcomes. Why is this work important? To better understand the mental health landscape of Harlem and to inform the development of community-based programming and services, a multi-stakeholder needs assessment was conducted. Among 393 participants in the study, 41% reported symptoms of depression, 48% reported symptoms of anxiety, 73% reported symptoms of loneliness, 26% reported symptoms of PTSD, 64% reported symptoms of interpersonal violence, and 66% reported symptoms of any mental health risk. Harlem Strong is currently flourishing and reaching milestones in the Harlem community. We currently offer our services at several sites that span across various sectors which include housing support, health providers, and community organizations. With 1236 consumers screened, 666 eligible for the study, 329 enrolled into the study, and 255 consumers who completed the survey over the span of 4 periods of our step wedge design, We are making strides in reaching 86.6% of our targets so far. Harlem Strong is here to provide free, confidential support to help manage stress, offer support, and connect to resources. Please share this with your networks, colleagues, and consumers so more of the Harlem community can benefit. Thank you for your support in the coalition thus far. We wouldn't be where we are without you. Together, we are strong, Harlem Strong.
Thank you. So while Harlem Strong is focused on adults, today's session is focused on youth. We actually have, the BRY program in partnership with DOH, and PAL, which is the Police Athletic League in Harlem, is one of our partners. So they also offer services for youth through BRY. So if anybody within the coalition, needs that referral, we're happy to connect you all to BRY. And I think, that there's definitely a number of organizations within Harlem Strong that focus on youth. And so we'll hear a little bit more about them a little later. But in general, Harlem Strong, it was developed to address the rising mental health and socioeconomic inequities that we see in Harlem. And a few years ago, we got together and we decided that one of the things that's really important is to build a coalition, to have a network of organizations, different types of organization, multi-sectoral network come together to identify the needs and help facilitate the connection to care across the various services. And so we've done that. We now have probably over 100 organizations that's part of the network that come in and out at different times. We've also been focused on capacity building. So every period we've been doing trainings on mental health task sharing, and we just finished another round of training, but we will be making more training available. So if anyone here, has folks within your organization that want training on mental health task sharing, please feel free to reach out to us and we can work something out. Our goal is to place navigators in community settings to help provide some of the mental health task sharing. So the navigation support services, which allows them to, integrate like screening, psychoeducation, very brief stress management into a variety of different organizations like affordable housing, primary care, community-based organizations. And lastly, we want to have local data. We want to understand how this works within Harlem. We're evaluating it in a randomized control trial, and we look forward to seeing the results and being able to make recommendations from what we find. Next slide, please. So this space here, this coalition meeting, we have quarterly, and the goal here is to provide an opportunity for all of us to connect as professionals, to strengthen the vital partnerships within the community, contribute to collaborative efforts, and share knowledge, resources, share events so that we can all support one another and know about what's happening within the Harlem community. We've had this is our 8th meeting. So usually a meeting has like different themes. And so this one is on youth mental health. We've had ones focus on immigration, benefit programs, men as well, and faith-based community. And if there are topics that you all are interested in, please feel free to add them into the chat. And, we'll keep that in mind as we plan for the next quarter. Thank you. So now I think, can we go on to the next slide, please? This is wait, go back. So we have probably over 100 organizations that's part of the coalition. Here are just some of them. We want to welcome a few new coalition members. One is Grants Associate, which is a workforce development agency, and they've been really great. We've been able to screen several hundred folks within Grants Associate in the last few months, helping to support stress management and wellness programming into their services. So that's been really exciting. We also have CCHP joining us as a coalition, as a gateway site this period. And so they'll start providing services soon. We're very excited to have them. They're also at FQHC in Harlem. And actually, last week, the East Harlem Neighborhood Health Action Center held a forum on immigration, and that was really great, where a number of organizations in Harlem got together along with the city to talk about the challenges in the community and resources. And we talked a lot about Harlem Strong actually in that meeting, and shared about what we're doing here in Harlem. And folks were really excited about joining the coalition and being part of our work. So thank you all for, being part of the team and helping to make this a successful initiative. And we're looking forward to expanding it more. I see that, let me see who's on the call here. Do we have someone from the East Harlem Action Center on the call? See. Okay, we don't. I thought we did. Next slide, please. For anybody who is not part of the coalition already, feel free to join us. We have trainings available. We have resources. There's a QR code there you can access. And then there's also a survey that we would love for you to fill out, and we'll talk a little bit more about that at the end. But if you scan that QR code, it'll also lead you to information. So as I was saying before, we are now on our 5th round of doing trainings. We just completed the training. The next round for us will allow us to add in technology component. We are developing a client management platform that will be made available to community-based organizations that don't have an electronic client management tool. It'll be made free to use, and we're adapting it to make it simpler. It was based off of OpenEMR, which is an NIH-funded open source platform that is really meant for health services. And so we're trying to simplify it so that it'll be easier for community providers to use and much more responsive to their needs. So be on a lookout for that and let us know if you're interested in using that. Next slide. Okay, so in terms of our implementation progress, HCCI is, our lead partner, and we've been integrating mental health support services there through their navigators and our navigators. We've been placing navigators into sites, and we've also been training navigators at different sites. So that's been really exciting. Mark is also another community-based organization that's partnered with HCCI, and there we're integrating the stress management curriculum into Seeking Safety, and addressing both trauma and recovery there. There's actually a number of other groups that we've been able to incorporate our work into. At Ryan Health, we've been embedding wellness sessions into the primary care and other health services. There's been a lot of street side screenings and outreach, so that's been really exciting. At Hope Community, there's been a lot of creative efforts in terms of integrating screening and outreach, wellness checks at farmers markets. There's been a pain and sip, which was really exciting and fun. And then other programs to incorporate wellness, including, I think, in their open house or their new center where new residents, like their first stop for new residents, we're incorporating screenings there for new residents. And then Grants Associate, which has been really great partner, they're a workforce development agency. So we're integrating some of the things that we've been doing in Job Plus with Grants Associate and supporting mental health and employment support and integrating that. So that's been really interesting for us. And we're seeing a really big reach there at Grants Associate as well. So thank you all. That's been kind of the update on Harlem Strong. Now I'm going to pass this over to Vidya, who will introduce our speakers, and then we'll get into the main purpose here today. Thank you.
Next slide, please. Yeah. Okay. Welcome everyone once again to our Coalition 8 meeting, which is focused on the youth mental health. I'm Dr. Vidya Sharma. I go by Vidya, and it's a pleasure having you all here once again. So as we transition into the speaker presentations, we'll hear different perspectives on youth mental health, from research to frontline providers to family experiences. Each speaker will share their work and we'll hold questions for the panel discussion. But please feel free to drop your thoughts or questions in the chat box or hold it as we go. Now I'll go on to introducing Dr. Prerna Arora. Our first speaker is Dr. Arora, Associate Professor of Psychology and Education at Teachers College, Columbia University. Her research focuses on understanding access and quality of care for historically marginalized youth, especially looking at risk and protective factors for depression, barriers to help seeking, and culturally tailored school and community based intervention. Dr. Arora, we're so glad to have you with us. Over to you.
Thank you so much. You guys have my slides that you'll be sharing?
Yes,
So
pulling up right now.
wonderful. While they're doing that, I'll just share that I will not be able to stay for the entirety of this talk today. So I am going to share my email in the chat right now. I'm happy, if people do have questions that are burning, they're welcome to put it in the chat and I'll do my best to answer them. But you can also email me later, and I'm happy to follow up with any questions that result from this. I was tasked here today with speaking a little bit about the big picture when it comes to youth mental health. And so the goal for my presentation today, I have an agenda slide whenever it's shared, is going to be about discussing what's going on, framing youth mental health services in our country, nationally, and also with a snapshot of what's going on in New York City. I'm going to focus specifically on disparities that we are seeing. I'm going to talk a little bit about some of the risk and protective factors that we know exist with regards to youth mental health. You can skip this slide. We already talked about me, so here that is, and then I'm focused on the agenda right now. So a little bit about risk and protective factors. I'm going to talk a little bit about barriers to help seeking that we have found for youth, particularly youth of color when we're talking about mental health services, and then some of the potential solutions my team works on. There are many, but I'm going to highlight a few that we focus on in particular. I hope this is of help to you guys. And again, please, if there's questions, I'll do my best to answer again, because I won't be here later. Next slide, please. So first, at the national level, I know many of you have heard about this from your work, but also, in the media, and how there's been a huge increase in the amount of youth mental health needs over time, with a call of a youth mental health crisis within the last few years. Obviously, these issues existed before, but were exacerbated by the COVID-19 pandemic. I have some data here from the last time CDC has published, analyzed their data from 2021. And it reveals stark concerns with youth mental health need, with more than 1 in 5 youth endorsing mental, emotional, developmental, or behavioral health disorder. When we're thinking about, non-diagnostically, but just about symptoms, 4 in 10 are endorsing feelings of persistent sadness and hopelessness, with 1 in 5 seriously considering suicide. In 2023, we had 1 in 3 U.S. high school students nationally indicate that their mental health was, quote, not good most of the time or always, which is extremely concerning. And nearly 70% of youth endorsing that they had experienced at least one, if not more, adverse childhood experiences. I believe we have someone talking about that more in this presentation, so I won't belabor that, but just generally, ACEs, as many of you know, are preventable, potentially traumatic events occurring to youth before the age of 18. Next slide. Here I have a quick snapshot, essentially, which indicates over time what we've been seeing with in adolescents ages 12 to 17 as it relates to youth mental health. So overall, we have seen an increase across areas: behavioral conduct problems, depression, anxiety, all mental health concerns from 2016 to 2023. Again, things that we've heard about, but are becoming clearer and more concerning over time. Next slide. There are significant, within the numbers that I've provided above, mental health disparities that exist among this population. So approximately, and I put a few groups here that we see a lot of mental health disparities occurring within. So when we're thinking about racial and ethnic minoritized youth, I'm talking about youth that are considered that are systemically marginalized within the United States because of their race and ethnicity. BIPOC youth, ages 7 to 13, about half of them indicate experiencing a mental health disorder before 18. So that's higher than our about 25-30% in across all samples. In immigrant origin youth, we're defining here as youth with, first generation newcomer, first and a half generation, or children of immigrants, have up to twice the rate of depression, anxiety, and PTSD compared to their non-immigrant counterparts. Youth from low SES backgrounds are also particularly at risk and are 2 to 3 times more likely to develop mental health problems as compared to youth with high SES resources. And also youth living in urban areas, we found, have increased prevalence of anxiety, depression, and behavioral problems compared to youth living in suburban or rural areas. Next slide, please. Within New York City, from 2019 to 2021, 15% of youth, I have citations here for people who would like to access this at a later date, from these ages, so very young children, had a mental health diagnosis. Among these, anxiety disorders were the most common, followed by depression. In 2023, we're looking at a slightly older age group here in New York City. 48% of adolescents indicated experiencing depressive symptoms from mild to severe. So almost 50% of kids in this sample in New York City. Across this sample, again, racial and ethnic minoritized children were more likely to have a mental health diagnosis Latinx, Black, and white children were more likely to have a mental health diagnosis as compared to Asian and Pacific Islander children. And, there's many reasons for that, and we can talk about that as well. Next slide. I have a little bit of New York City DOE data. Many of our students, not all, but most attend a New York City DOE school. So from 2021, 38, almost 40% of New York City high school students reported feeling sad and hopeless, so much so that they couldn't participate in typical activities. And that was an increase from a decade prior. This rate was about almost 50% for Latinx and Black students compared to white students. Again, of this sample, 21% of New York City students seriously contemplated suicide, with nearly 1 in 10 reporting a suicide attempt in 2021. Thank you. I see some questions about intersectional rates. We know that those are higher. I didn't report them here, but anecdotally, some of the data, I didn't report them for 2 reasons. One, that data is harder to find by demographic. But 2, generally what we know is when we have intersectional identities, as an example, we know that sexual minoritized youth or sexual minority youth and BIPOC youth have even higher rates, as an example. And so a lot of these factors can be combined risk factors. I'm not talking about protective factors here, and those are also can be combined as well. But we know that, when we're thinking about New York City youth, we're talking a lot about a lot of these risk factors are co-occurring. And I'm going to get to that a little bit in our next example. But thank you for the comment. And that is absolutely 100% accurate. Next slide. I've presented a few models in the next few slides. I'm not going to go through in too much detail, but I just want to make you aware of them as we're thinking from what I've gathered with this group, the majority of people work with adults, but obviously have interactions with children and parents, etc. And when we're in the kid world, we think a lot about some of these models that when we're considering mental health risk and protective factors. This also relates to some of our intersectional identities and our intersectionality and multiple risk and protective factors as well. So many of you might be familiar with Bronfenbrenner's ecological model. My main goal in bringing this up is to think about, when we're thinking about the children, it's critically important that we think about the system in which they're nested. So Bronfenbrenner essentially here explains that children, that the environments that they reside in influence each other. So the microsystem, when children exist within their family, within the context of their schools, within their peer groups, within the services that exist in their communities, within their religious organizations, daycare, etc., and that those interact with larger systems, including extended family, community neighborhoods, mass media, social services, and again, broader when we're thinking about policy, ideologies, changing politics, some of which Dr. No brought up at the beginning of our presentation. All of these interact to influence mental health concerns that our children are facing and other through the development of these mental health concerns. Next slide, please. There's a few models that also I think are particularly important when we're thinking about models for development of mental health concerns among our most minoritized children. And a few of these, and again, I don't want to belabor this kind of academic models, but I do want to talk about the fact that there's people out there that have been for a while focusing on the fact that when we're thinking about our most minoritized children, we have additional risk and protective factors that we need to think about. So in this model, which is a really important one, the integrative model for developmental competencies for minority children, this is from 1996, but again, very relevant. We're thinking about the different areas in which the different areas in which risk and protective factors can occur. And so according to this model, one of the big pieces that we have to think about with minoritized children is also variables such as social position, race, class, ethnicity, gender, racism, prejudice, discrimination, and oppression, and how that permeates a lot of the settings in which they live and the settings that are influencing them. So this is kind of like a bit of an add-on to Bronfenbrenner's. What else do we need to think about when we're thinking about society's most historically underserved kids and families? A citation there for you if any of you are interested. Next slide. Here's another one that I know many of you work with immigrant origin children. And again, this is a particularly relevant group in terms of unique risk and protective factors, considering the breadth of the concerns and protective factors that these individuals face. So this is an integrative risk and resilience model for immigrant origin youth. And we have these youth within the context, at the individual level, we're thinking about very similar risk and protective factors. But in addition to, what we might face, what others youth might face, we also have to think strongly about the political, social context of reception, acculturation challenges that these youth have to, may or may not have to handle, and other sorts of concerns in addition to other risk and protective factors that exist. I see that there's some questions about additional nuances with the rates, and I'm happy to share that with the organizers after the fact, some reports that maybe you can disseminate if helpful.
Yeah, we would love to do that. Thank you.
Sure. I'm doing my best to I know you said questions after, but I know I have to go, so I don't want to upset anybody, or not upset, but rather disappoint anybody with some answers that are important. Next slide, please. So with all of these, there's many barriers to mental health help seeking that exist. You all know this, you work in this community. When we think about children, we have a few additional ones that we try to think about, or maybe are a little bit more nuanced, or maybe present differently when we're thinking about kids. So I like this model for thinking about different areas where barriers exist, and I like to group them in these 4 categories: individual factors, social, or rather, I like how this is organized: individual factors, social factors, the therapeutic relationship, and systemic or structural factors. So when we think about what are some of the things that get in the way of asking for help, things at the individual level is how much and obviously these have larger impacts because of family, culture, etc. What do we know about mental health? What are the terms we use to describe mental health? Are those consistent with the majority terms to use? Do we recognize this as a problem that has a solution, etc.? What about factors like embarrassment or social stigma, or saving face, or what the community might think of me asking for help? We also have barriers related to the perception of the therapeutic relationship. Is this going to be a confidential experience? Is this going to be one that the person actually gets me? Are there availability of providers that understand my background, or that look like me, or that speak my language, and how is that going to impact how much this person can help me? And then finally, we have some of the systemic or structural barriers that we all consider, things like cost, insurance, logistical barriers, getting their parents, getting their children, getting there themselves, and just whether or not services exist in the community. We know that for all of these barriers, these barriers are disproportionately these barriers are disproportionately exist within minoritized youth, whether that includes racial and ethnic minoritized youth, low SES, youth who live in certain urban settings, etc. And because of all this, there is a disparity in both initial engagement and ongoing retention in mental health services, whether or not people start treatment, know where to start treatment, get resources for starting treatment, and whether or not they stay once they've started. And I think many of you have heard the statistic that for a child, the average number of sessions is 1, or the modal number of sessions is 1. Next slide. So my background is a lot in community and school-based mental health. And, one of the things we've talked about a lot are schools are a critical social security, safety net, and also a critical point of entry for school mental health. Kids in schools have a connection, ideally, if they're doing things well, have a connection with family. They're uniquely positioned to identify early risk and protective factors. They have the potential to overcome some of the relationship factors that might exist in other medical systems. Again, potential, not necessarily the case. They can be embedded with, the services can be embedded within the setting itself, so it might reduce some stigma, it might reduce some logistical barriers, and indeed, many kids who receive services receive them within the context of schools. Next slide. However, despite this, we know that many schools in our city and across the country have barriers to integrating mental health service as well. Insufficient funding, inadequate access to licensed mental health professionals, all of that exists as barriers for integrating well integrating mental health services within schools. So some New York City DOE specific data, while New York City DOE has implemented many supportive mental health programming in K through 12 public schools, only 37% of New York City DOE schools had structured mental health programming built across the MTSS, multi-tiered systems of SAPRO public health model. Even there is inadequate ratios of students to mental health professionals, whether we're talking about school counselors, social workers, or school psychologists. And there's also, because of the amount of need, low staff attendance at mental health trainings. When they do exist, when they are available for free, there's a lot of barriers to actual attendance at those professional development trainings. I think I'm running out of time, so I'm going to go very quickly. Next slide. I just want to talk very briefly about 2 solutions that some of my team works on. There are many, and I think many of you hear about this. I was asked to say, like, well, so what do we do about this? So what are we doing about this? And what are some of the things that the literature says is important to do about this? Is think about how we can culturally tailor interventions to be more likely to be well suited for our most vulnerable populations. How do we make sure that interventions are well integrated in school communities? How do we make sure that they're address the relevant risk and protective factors for the community? How do we make sure that we increase engagement and address things of concern like stigma, like the Therapeutic Alliance? How do we make sure they're culturally informed and culturally tailored so people are less likely to drop out? And I've included some examples here of well-supported evidence-based treatments that are used in schools with a lot of support with racial and ethnic minoritized populations, and others exist as well. But what do we know about how we can make sure to keep these people, keep youth, keep families engaged in treatment and have more positive outcomes? So again, that's one approach. And then my next slide, very quickly, another approach that is critically important is the use of participatory approaches to when we're developing and evaluating interventions. So how much, and I think I don't need to belabor this because this is exactly what your group is. How much are people talking across systems? How much are interventions grounded in and address concerns and barriers faced by youth and the community? We focus on co-developing interventions with some of the populations we're working with that are developed in and led by community members who live with these individuals to be more likely to be more effective and to engage hard to reach populations. And again, that's what you guys are all doing, which is wonderful. Next slide. I have my email here for questions. And obviously, I know we're going to talk about that at the end too. So I'll stop. I think I've used my 15 minutes and then share with the next person. Thank you for your time. I hope this was helpful.
Thank you.
Absolutely. Thank you so much, Dr. Arora, for highlighting the critical, mental health needs of underrepresented youth. This is, I mean, quintessential to understand how we can better support them. So just want to note for everyone, we're keeping track of all your questions in the chat. And since Dr. Arora has to leave a little early, we'll make sure to get your questions out to her and share her responses with the group later. Our next speaker is Dr. Richard Reeves, Associate Director of Intervention and Prevention at YAE Services. He brings over 4 decades of experience working directly with East Harlem youth. His work includes developing prevention and supporting programs, training probation officers, and counseling as a licensed healthcare chaplain. Richard has a deep, long-standing commitment to strengthening youth services in our community. Richard, we look forward to your perspective. Thank you.
Thank you. Thank you for having me. That was a wonderful presentation. I just want to say, very, very informative. I took a lot of notes. It bothers me that these areas of need are still not being appropriately addressed because of all of the issues that you made clear and stated. So thank you for that information. Today, I want to really talk with you about, I want to integrate an idea, the concept that connects to youth development, but it's integrated around the idea of adverse childhood experiences and stress and trauma. So in order for me to do this, I want to kind of create 3 buckets, okay? The first bucket is, well, I'm gonna draw some things. If you can see me while I'm presenting, even if you want to remove me from the screen there, my picture, I'm gonna write something, and if you can't see it, just let me know. Okay, it may be possible to pin my screen, but if not, I can just go ahead and do this. But I want to paint these 3 pictures for you because I think that this is important for us to have this conversation about providing sufficient and necessary supports to young people and how this is related to trauma, stress, and adverse childhood experiences. So the first little bucket is in the middle here. I'm doing diagram work with you, okay? And this first bucket right here, I want you to think about it from the perspective of a generally healthy developmental process for a child or a young person, okay? this bucket over here, I want you to think about it. So let's just say everything's good. We're going to use the word good for a moment. Okay. Okay. Then we're going to have a bucket for high stress. Okay. And then a bucket for possible trauma. Okay. And I'm just kind of shortening this. But what I want you to think about is here's our 3 buckets.
Mm-hmm.
Okay. A generally good developmental experience for these young people, their family systems, their community systems, from an environmental point of view, from an integrated ecological point of view. We have this, everything's working right. Everything's generally good, and young people are able to move forward well. Okay, I want to add this one here, high stress. Okay, high stress environments. And when we think about high stress environments, this is where the adverse childhood experience model brings together trauma, abuse, and circumstances and conditions that produce high stress responses in young people. Okay, so now, if everything is going well, young people are not only able to develop in a biopsychosocial sense, but they're also able to develop coping skills, skills that connect to resiliency, adaptation and adjustment capacities, life skills. And through that process, they become more insulated and protected from the dynamic impact of high stress environments or potentially traumatizing environments.
Mm-hmm.
That journey gives them a better future projection in terms of health and wellness, psychologically, socially, behaviorally. But a lot of our young people, and I'm so glad that the presentation that laid out all this information was before me, because it tells us that when that journey is affected by all of these different things, we're going to have negative, at-risk, high-risk outcomes. And if we don't provide the necessary intervention and prevention strategies to mitigate some of the dynamics that are going on in this experience and in this journey, we're going to end up not just having need for intervention and prevention, but a greater need for treatment services.
Mm-hmm.
And that means that these situations have produced conditions that we would class as clinical in nature, right? That it's not just a young person responding in stress and they're able to adapt and adjust, but we're starting to see regularity in these conditions in their lives. So they're able to say, I'm more depressed, I'm more anxious, right? My stress levels are very high. Circumstances and situations are affecting me. It's affecting my physical well-being and so on over periods of time. So my general population of service in the area that I work within Union Settlement in East Harlem is adolescents and young adults, high risk, at risk youth, and young people that have had engagements with the justice system and that also are coming from family situations or community situations that have involved gang activity, crime, violence, and gun violence. I've worked on the front lines in these areas, as well as doing trainings and development for those who work in these areas. So part of what my experience has led me to see is that it's not only important for us to try to figure out the best way to provide these clinical services, but we have layers of intervention and prevention that are critical to reducing the recurrence of these patterns in young people's lives. Their psychosocial, ecological, or environmental realities are very stable from a unhealthy and dysfunctional perspective. And so we're seeing young people that by the time they're hitting their teens and their young adults are demonstrating a higher level of vulnerability for recurrence of mental health issues, right? Because the coping skills and the resiliency and the adaptation abilities are not actually being well reinforced. So a lot of them are able to get some level of service, but a lot of the services are not meeting the need at the level that we're talking about, and that was laid out already in the previous presentation, right? So because of all the barriers to engagement with services, our young people are kind of left to themselves to fend for themselves in terms of how they're going to cope and deal with these environmental, psychological, and social stressors, right? So I want you to think about it from the point of view of in the ideal world, this young person is able to navigate through these stresses and through circumstances because they have the social, ecological, family, interpersonal support systems that enable them to develop the coping skills and the strengths and the life skills that shore them up for adjusting to life circumstances, dealing with life circumstances. Their tendency to move into clinical levels of sadness and sadness to depression, stress, fear to anxiety, like those patterns become reduced because of those coping capacities, because of the resiliency and so on. If we don't get those things developed, we have a higher chance of young people that are living through possible traumatizing experiences to move from a adjustment growth post-trauma growth perspective in their life to a PTSD, low level, high level patterns, symptomologies, and so on in their life. And so now not only are they dealing with having to live through this stuff on a regular basis, but now they're having to cope with the pressures of their own psychosocial responses to these circumstances. And that makes it that much more difficult for them to navigate the journey of healing and restoration, because now they have to cope with their own responses to the circumstances. I hope that makes sense. I hope how I'm saying this makes sense, but it makes it that much more difficult for them to properly engage with circumstances because some of them end up self-medicating, some of them end up in high risk, at-risk situations that reduce their ability to actually move in a healthy direction towards help, because these things are providing a kind of surface level coping system. And so part of what this means is that service provision to help young people move in a healthy direction has to be multi-layered, right? So we need the prevention services. So thumbs up if you're with me. Right, okay, all right. So I want to now move from those three buckets to looking at what I might call 3 zones of care, okay? When it comes to these young people. One zone is what we call the prevention bucket, okay? The prevention zone. And I want you to think about it from this point of view of getting to the issue before the issue becomes a clinical concern. Before we see stabilizing of further psychosocial mental health concerns, okay? Most of the time, the prevention strategies are targeted towards younger children so that they become a part of their developmental journey. And they end up building these coping mechanisms and prevention strategies into their personality systems and their ways of coping, okay? Then there's what we look at as the intervention strategy. We're starting to see red flags. We're starting to see issues that are popping up and showing themselves up in the children or in the young adolescents. And so we want to think about intervention as a cutting in and a redirection. What makes intervention important is it enables us to get to these conditions before they reach a clinical level. That matters a lot, especially for adolescents, because they're already dealing with transitional processes. So if we can get the intervention into the childhood and the later adolescence, it will better ensure that these young people are moving towards healthy young adult independent living.
Mhm.
If we don't get in at that window, we're going to run into obstacles that don't just deal with the conditions themselves, but deal with the normality of human development, that things become more stable, that patterns of functioning become more habitual. And so now we're not just dealing with trying to get there before it becomes an issue. We're dealing with trying to break cycles of neuropsychological and behavioral patterns that have become, from a neuroplasticity point of view, have become integrated in their synaptic systems, right? So from that development point of view, we know that we've got a window of change possible into the mid to late 20s. But when these patterns are also connected to high stress, also connected to the hormonal systems that connect to those stress levels, defensive processes, reactive process can become very stable very fast. And it's one of the reasons why post-traumatic stress patterns easily become normalized in our functioning. Even though they seem unhealthy for us, they become normalized quickly, okay? Because they become reactions to circumstances that to our systems are life-threatening. So here we have the prevention, here we have the intervention, and then we have the treatment, okay? And what's really critical about the treatment process is, if we're seeing all of these indicators showing themselves up early in the child's life, then the treatment process is going to have to get in there early. And if we have the means to get in there early, then we can help redirect and build healthy coping into the young person to help their systems better adjust to their circumstances if the situations cannot be changed right away. Okay, but if we find that our treatment strategies are coming in at a latter time period in development, we run right into real issues related to stability of personality, adjustments in a coping mechanisms that come to, I'm moving away from my family system, I'm developing my own functioning, but the functioning is not all that healthy. You know, the generational gap is wider in our time than it used to be, so the influence of older individuals is less. So now they begin to identify with the influences of peers, right? And people that are right above them. So that means that if those influences are not healthy and positively reinforcing, then it just reinforces the negatives that are in their life. And they begin to stop listening to those who might be able to provide healthier possibilities to them. So part of what we're trying to do, and what is important for us to try to do as a collective, is to look at the process of engaging young people in phases that enable us to drop in these prevention, intervention to treatment strategies. Okay. That means that we all have to begin to build networks of connectedness as service providers, so that we can begin to, which is very difficult, the way that funding operates oftentimes and the way that systems operate. But from a direct service point of view, we have to begin to develop these networks so that those who do enrichment and recreational services are getting the linkage to those who provide the prevention and intervention stuff and the treatment stuff, right? So we're able to then say, oh, I'm beginning to see stuff, right? From that perspective, we also need to begin to shore up the knowledge base of those who are on the recreation, arts, education zone of service, so that they have more skills in what we commonly call emergency or crisis, mental health crisis, first aid strategies, to identify with young people what are some of those issues that are the red flags so that referrals can take place. Oftentimes, those individuals as staff don't quite know what to do and don't quite know what to look for. So they do have their skill set in education, in the arts, and so on, but they don't know quite how to identify young people that are having mental health crisis, right? So part of this is training and part of this is network building so that we can begin to get past some of the barriers to service provision and access that were already identified by our previous speaker, right? That block timely interventions for our young people. Last thing I'll say is, if we as providers, I'm going to say something for a quick moment about modeling around a medical model of biopsychology when it comes to this stuff, as opposed to a psychosocial model, right? That says it could be foundations that are biological, but all of these social systems and social factors have a major role to play in in the lives of our young people. If we can begin to think about these things from the perspective of our young people just trying to live in worlds and environments and circumstances that tend to affect anyone in these ways, we do not over stigmatize young people that are really in high level response to high stress and traumatizing circumstances, to family systems that are very unhealthy or dysfunctional, right? And the older they get, the more society loses its sense that these young people are just trying to survive. And they become more focused on adult responsibility. And we are in a time and a climate where that seems to be increasing, where we want to deal with older adolescents and young adults as if they don't have mental health concerns. It's just bad behavior. It's just they're young adults. Take care of yourself. Stop being a bad kid. Stop being a bad person, right? And those kind of social system messages produce no developmental affirmation that for some of these kids and some of these young people, they have survived some really intense stuff and they're still here, right? And they have not gone down the path of complete disconnect and suicidal ideation and action, right? But they are trying to navigate and cope with great deficiencies. And if we can provide the supports necessary, we can then begin to shore them up so that they can do better. Thank you.
That was fabulous. Thank you, Dr. Reeves, for sharing such a compelling perspective. You can see in the chat also, it's so amazing. But again, thank you for your perspective on ACEs from the front lines, and also emphasizing the critical importance of age-appropriate prevention, intervention, and treatment strategies, aligned with youth window of change and the importance of network, which is also a prime goal for Harlem Strong. So without much ado, our next presentation is from Dr. Geeta Gopalan, Associate Professor at the Silberman School of Social Work at Hunter College. Dr. Gopalan's research centers on families involved in both child welfare and mental health services, with a focus on reducing barriers to care and developing interventions that integrate peer support to improve outcomes for children and families. Dr. Gopalan, we are excited to hear your insights. On to you.
Thank you so much. I am both honored and humbled to be here today with these esteemed and very knowledgeable speakers. And so my hope is that you all will get something from this presentation as well. So I'm going to shift focus to the parent, caregiver, family experience And my talk will focus on how we can support families and youth with mental health needs, with a particular emphasis on what can we do now to manage and prevent crises. Oh, okay, so bear with me one second here. All right. So just a little about me. I am an associate professor at the Sylvan School of Social Work, but in my former life, I was a clinical social worker here in New York City. I worked in therapeutic foster care at Graham Wyndham Services to Families and Children. And I also worked in the psychiatric emergency room at Kings County Hospital in Brooklyn. And so what I'm going to talk about today integrates research, but also a lot of my clinical experiences. Um, Working with families, many of whom are in crisis. Okay, so our prior speakers have talked a lot about why youth mental health matters, and I'm just going to reiterate some of the major points that they've talked about. We are in an ongoing youth mental health crisis, and this is not something that has changed over the last 20 years. I was talking about this 20 years ago. There's many children who need mental health services who express significant clinical symptoms of depression, anxiety, PTSD, but most children in this country do not receive that treatment. Part of the reason is service use is particularly low in poverty impacted communities because we have a real shortage of available mental health providers trained to deal with these issues in the community. So one of the reasons among many is that there's not enough providers to go around. So there's an opportunity here, particularly with Harlem's strong coalition and this emphasis on task sharing, to figure out how can we support families now, given that we have this shortage of mental health providers. To underscore the importance, again, just reiterating what our prior speakers have said, untreated youth mental health issues will get worse. They can get worse. They can exacerbate into more intransigent problems that are harder to treat. They can further impact youth's social functioning, their academic functioning, and their occupational functioning. So this has impacts well into their trajectory into adolescence, young adulthood, and adulthood. We also know that youth struggling with mental health difficulties are at an increased risk for suicide. They're also increasing risk for social service involvement in the future and criminal justice involvement. And what's really also critical is that this costs us as a society money. This is a very costly thing because of all of these downstream services. What that means, what we as a society have to pay in order to address these particular issues. And while we've talked a lot about how the kids are not okay, the parents are also not okay. Parents and caregivers whose children struggle with mental health difficulties are struggling themselves. They're struggling with how to manage their youth's mental health needs and behaviors at home and at school, but also how to navigate an incredibly complex service system. And it's important for us to understand how dealing with youth mental health issues actually affects families. What we know from the research is that youth mental health concerns, behavior problems, depression, anxiety, PTSD, these can also increase caregiver stress and caregivers' own mental health difficulties. We see a lot of issues with co-occurring caregiver mental health issues and child mental health issues. Youth mental health issues also lead to a lot of disrupted routines and responsibilities. One of the biggest issues that I've heard from parents is the schools calling them at work, telling them to leave work and pick their children up from school, which can really interfere with their own employment and their family stability. We know also that mental health difficulties in kids can impact family relationships. It leads to strained communication and strained relationships. It can also lead to further social isolation. Other kids, other families don't want to play with kids that have behavior problems, or they maybe feel so isolated, so anxious that they may isolate themselves from the community. And this is really critical because all of these are risk factors then for future maltreatment, for future child welfare involvement. So it's not just that we have to address youth mental health concerns, we also need to support the families that are also experiencing the stress while youth are struggling with their mental health difficulties. So one thing we can do to support parents and caregivers is alerting them to some red flags of when kids need help. And so this is just a kind of recognizing signs of crisis. Um, and I've just organized it into what kids say, how they behave, and like how they present in terms of their mood. So if we have youth that talk about an interest in death, dying, killing themselves, feeling hopeless, feeling like there's no purpose in life, making comments that things would be better off without them, or saying they can't handle things anymore, that's a red flag. Something problematic is happening. That is a sign that this child, this youth needs further support and intervention. But oftentimes our kids will not tell us what's happening, and so we have to rely on their behavior. Some kids, particularly those who are thinking about killing themselves, may start preparing for a suicide attempt. They may start rehearsing that behavior. Other times we may see increased alcohol or substance abuse. Now, we know that many youth experiment with alcohol and substances, but when it becomes more consistent, when it starts to exacerbate, that's telling us there's a problem here. We also know there's a problem when kids start withdrawing from other people or activities that they used to really enjoy. Also, we know kids are in trouble when they start engaging in dangerous or harmful activities, something that's different from what they would normally do. When they start giving away favorite possessions and saying goodbye to people. And as a clinician at Kings County, what I would also look out for are any acute changes to how are they sleeping? How are they eating? Are there any changes in their weight? Are there any changes in their hygiene? Are there any changes in their grades? That's a signal that something's happening and that intervention is needed at that time. And then we come to mood. How are kids presenting? How are they feeling? Kids in crisis many times will talk about feeling unbearable pain, feeling trapped, feeling hopeless, struggling with anger that they cannot control. In fact, many kids you'll see a red flag is a lot of angry outbursts, a lot of recklessness, a lot of impulsive behavior, or dramatic mood changes. But anxiety and agitation is also a sign of crisis because anxiety is so uncomfortable, as is depression and sadness. So when we see these things in our youth, that is a signal that something is happening. They need to get help. And so I thought it would be helpful for all of you. Just what are some basic do's and don'ts that you as providers can do, as people, as navigators, but also what you can tell parents and caregivers? So I think it's important when you're faced with these red flags and you're talking to youth to be direct, to talk about just openly and matter-of-factly, to normalize that everyone struggles with feelings of depression and sadness, anxiety at some point in their lives, and that it's okay to have them. It's also important that we be willing to listen, to allow youth to express their feelings without judgment, without lecturing on the value of life, or without saying this is right, this is wrong, how you're feeling. Just accept that they're feeling this way. We also want to be involved, get involved, be available, show them that you want to support them, show interest in what's happening to them. And part of that is taking action. So getting help, and I'll talk about some resources that may be helpful, but also looking at the environment. We talked a lot about the high rates of suicide among youth, and that means really securing the environment, locking medications, locking sharp objects, locking toxic household chemicals, keeping an open door policy if kids express suicidal ideation so that they can't close the door, parents can look at them. And so all of these things are really important. What we don't want to do is dismiss kids' concerns. Oftentimes I hear from others, well, maybe they're just asking for attention. Maybe they just want to get out of something. maybe they do, maybe they don't. I am very aware that I cannot read minds, and I assume most of you can also not read minds, because if you could, you'd be making a lot more money than we're all doing right now. So given that limitation, I'm going to err on the side of caution and assume anybody that talks about these feelings, they're serious about them. They mean them. It's also important that we don't act shocked, because this will put distance between us and the youth. This will potentially be perceived or land as judgment, even if that's not the intention. So we have to be mindful of our own reactions to this. It's also really important that we are not sworn to secrecy. I have heard from a number of kids who've asked me, can you keep a secret? Can you keep a secret? And if they tell me things like they're going to hurt someone, or someone's hurting them, or they're going to hurt themselves, I can't do that. So it's really important when you're interacting with kids that you're not sworn to secrecy. Be honest with them and upfront about the limitations of confidentiality. I've also provided links to some really important assessment resources. So there's 2 suicide screening questionnaires that are freely available, as well as some child and caregiver assessment questionnaires. So if you'd bear with me a second, I'm going to share my screen to show you just these web resources. Okay, so this is where we can access the Columbia Protocol for Suicide Screening, and it gives you step by step what to do in case, as people fill out this questionnaire. And it can be used by community members. It's not specific to anybody that has specialized training. Similarly, the Ask Suicide Queen screening questions also is another screening tool that anybody can use. It doesn't require specialized training, but it can provide people with structure for what questions to ask and when to know that immediate intervention is needed. I also wanted to share this research project Teach. This website has a number of assessment clinical rating scales for children and for caregivers. So right now, you can, if you wanted to assist your navigators or parents, even just like, is this actually a problem? There are general psychosocial screens that you can access here, where you can download the assessment measures. Also, this resource has scoring information too. And in the research that I have done, particularly with mental health providers and child welfare workers that have used these screening measures, when parents see that there's an objective rating that says your child meets clinical significance, for some parents, it's a relief. It becomes an aha moment, like, yes, this is something. This validates their experience. So I'm sharing this with you all because this is freely available. And this website also has maternal rating scales or caregiver rating scales as well. So then let me just stop my sharing here. All right. So in addition to these assessment resources, where can we go to find help? And so again, I put all the links and the hyperlinks in the presentation that you can access later, but I'm going to just share their websites themselves. So the first resource is the 988 Mental Health Suicide and Crisis Line. So this resource, it's available 24/7. It's staffed by people that are specially trained in crisis intervention. So if you or anyone you're working with, you just don't know where to go, who to talk to, where to turn, this is a first place to go. And so they can help with prevention, crisis counseling, as well as referrals and warm transfers to follow-up care. Another resource that I really enjoy using a lot both in school, but also in clinical practice is this California Evidence-Based clearinghouse for child welfare. And don't be discouraged, it's not just for folks involved in the child welfare system, but what it does is it's a repository of evidence-based treatments depending on specific mental health or issues that families may be facing. So let's just look, for example, depression treatment for children and adolescents. The site will give me a number of programs organized by varying levels of evidence, and they'll actually tell you how they rated these skills. And then you can go into any one of these evidence-based practices and find out more about the program. What's really important is that they'll talk to you about what are the essential components, how is it delivered, and for all of you, where you can get training and implementation, and also some relevant peer-reviewed research for you to read. And then the final place, another place that I want to ask us, once you see these evidence-based programs that are there are also prevention services through the Administration of Children's Services that offer many of these evidence-based programs. So I'm going to the Prevention Provider Directory, and here we have community-based organizations all across the city that are contracted by ACS to provide prevention services. And why I share this, because this is also a complement to clinical child mental health services, because a lot of these programs offer clinical evidence-based practices, functional family therapy, child-parent psychotherapy, family support. And so you can utilize this resource to also help link families, particularly if they're on a wait list for a child mental health provider. These are other places where families can access help. And then the final resource I wanted to share is peer services, both for caregivers, but also for youth. These are, New York City has a cadre of folks that have the lived experience of raising a child with mental health difficulties, but also youth themselves who have struggled with mental health difficulties. And I think of these folks as having really unique experience and expertise in what it's like to manage this on their own, as well as navigate the service system. And so these are also resources that I think are really important to share with families. And then before I close off today, I was tasked with just what are some basic things that we can do that don't require mental health license, that don't require specialized training. And so I'm going to talk about some evidence-based common element strategies to support families. So one of the first things that we can work with families is making sure that there are rules at home. And rules mean not just there's a consequence when a rule isn't followed, but also that parents are recognizing when kids do good work. We're catching kids when they're being good. A lot of times the kids that I worked with, they only get attention for when they get in trouble. But what we can do is we can set clear, consistent expectations. Part of that is identifying what we want to see the kids do. So instead of don't call people names, we will talk to each other respectfully. These are rules that everyone follows, but it's really important that something happens afterwards if a rule is followed or if a rule isn't followed. We can also ensure that responsibilities in the families are equitably shared. Oftentimes, there's usually just one person in the family who's doing everything. But I like to think of a family like a football team. I watch a lot of football because my husband watches a lot of football. And so it's not just the quarterback who wins the game, it's everybody working together. So we want to make sure that all kids, even the little ones, they have a role to play in how to support their family. And that caregivers set the tone and they are the model. So caregivers also have to be able to show that they can follow through on their responsibilities in order for kids to learn that same message as well. Another really important feature is in nurturing family relationships. And the best way to do this, and this is one of things I enjoy doing the most is prescribing family time. Having parents schedule at least once a week, could be even more, regularly scheduled family time. This is a time that is not going to be used as a reward or a punishment. It exists outside of children's behavior. It's something that parent families do regardless of how their kids are behaving. And during family time, I have to stress this constantly with parents. This is not a time to nag. This is not a time to complain. You can put that in the closet. You can do that at a later time. This is a time to enjoy each other's company with activities that everyone in the family enjoys. And what this can do is to help rebuild those nurturing family relationships and get parents and kids closer to each other. It's also important that we help families work on their communication. And not just respectfully communicating from kids to parents, but also from parents to kids. So we want parents to learn how to actively listen to their children, how to sit there and listen to what their kids are saying without intervening. We want them to learn like effective resolution skills, conflict resolution skills, learning using I statements as a way to do that, but also paying attention to our tone and how sometimes the message gets overridden by the tone sometimes. It's also really important that we help families identify what is stressing them out, what's stressing parents out, and what's stressing kids out. And then practice healthy coping strategies because these issues are going to help them support youth and caregiver mental health. And then finally, we want to increase their social support. We want to shore up both formal social support, whether through organizations, agencies, clinics, but also informal supports, people in the community, clergy. We want to help families reduce their isolation. And not only help partner with community resources, but also give families the experience of helping others, because that in and of itself can be really therapeutic. So with that, I'm going to end here today. I've provided my email if anybody has any other questions. And so thank you so much for allowing me to talk today.
Thank you.
All right. Thank you. Thank you, Dr. Gopalan, for highlighting the importance of supporting families and also equipping us with all these practical resources and actionable steps. Thank you so much. Now, to bring all these perspectives together, we'll now move on to our panel discussion on cross-sector collaboration. So in addition to our speakers, who we had the pleasure of listening to, I invite presenters from our next section to join us here. So we'll be joined by Lakeisha Grant, Deputy Executive Director of Mental Health Access at the NYC Mayor's Office of Community Mental Health, Isaac Scott, Director of Community Initiatives at Another Choice Youth and Family Outreach, and Chair of the Human Services Committee for Manhattan Community Board 11. And we also have Jamie Taxier and Kanye Wilkes. Jamie is the Director of Behavioral Health and Addiction Services, CCHP, and Kanye Wilkes is the Community Engagement Coordinator, CCHP. So with all these wonderful people on the panel, we can step into our next segment. I'll start the conversation with a couple of questions addressed to a speaker, but we welcome all our panelists to weigh in, and we'll open it up to the audience as well. So I'll go on to, first directed to Lakeisha. So in your view, Lakeisha, how can schools and community-based organizations collaborate or, ensure that youth feel supported and connected to mental health resources?
Thanks, Vidya. That's a great question. I think we heard earlier in our first presentation that many schools do have some degree of mental health services, but definitely not, adequate enough to meet the need, especially the growing need amongst school age youth here in New York City. And so I think community-based organizations our natural partners, particularly those that provide mental health services, are natural partners for schools, just based off of their missions in general to support communities. Here in Harlem specifically, we do have a lot of community-based mental health providers, and thanks to the work of Harlem Strong, we're growing that, growing the capacity to provide mental health services here in Harlem, not just with behavioral health providers. So I do think that identifying kind of for each school to try and identify what their local behavioral health, mental health, or substance use providers are, and talk about opportunities for partnership that could look like training for teachers and for staff at the schools. It could look like providing resources for after school programs. And so I think there's just a lot of different types of opportunities, and also I think willingness to partner.
Wonderful. Thank you. Does anyone else want to chime in or? Okay, great. So I'll direct the next one to CCHP, Jamie and Khani. So from your perspectives at CCHP being on the front lines, what's one strategy or a couple of strategies that has been most effective in supporting youth mental health in community settings?
Thank you. Hi, I'm Jamie. So recently, actually, CCHP was awarded a grant by Fidelis to expand our adolescent services. And so that obviously money helps. So that was very helpful in establishing more trainings for the staff. Right now, we identified a bunch of adolescent specific courses that our counselors will be certified in. And so most of our counselors right now are focused on addiction treatment. And so in order to expand those services and to build capacity, the grant allows us to do that. It also allows us now to expand our services to create a adolescent group for after school. So hopefully soon on Tuesdays at 5, we'll be starting that. I think just having that support from funders is super important. We obviously have to rely on outside funding in these days. And so having the recognition of the need for mental health in the youth is really important. And so I think what also helps is that we're an integrated clinic. So we have really wraparound services. And I think that really helps target the main issues and really involves the family. And so I think just getting the whole team on board and really recognizing the need in our community, especially, was really, really important. I don't know if you have anything else to add.
Yeah, I can add something. A point that Richard made earlier, just the idea of prevention. I think that that's one way you can remedy an issue a lot of ways when you're not when you integrate things for children at a young age, they build those habits on later in their life. So just having adequate resources to assist them in that way, creating events that assist them in that way, whether it be through giving help or connecting them to programs that may assist them later in life. I think all of those things are extremely important.
Great, absolutely. So I also wanted to, address Isaac from Another Choice Youth Programs. So Isaac, are you there? I don't see you pinned, but I think you're there in the participants. So, so how do you think coalition organizations and particularly Harlem Strong, support your efforts in the big picture? How much are they important? How are organizations important?
Good evening, everybody. I would start by saying, one, this meeting was very helpful. Just in all of the information that it brought. I come to this work rather with a lived experience, and I'm one of these young people that you've been talking about this whole meeting. So I am understanding it different. So I appreciate, these spaces where you all are able to kind of share this knowledge in a way where it seems very trauma informed this time around. You said that. It feels like young people will stop the cycles of harm will stop because of the information that was given out to me. And I really appreciate the presentation that was just given about supporting families, because we can't support young people without supporting families. It's impossible. Most of their trauma and everything they're going through is coming from, their upbringing and what they're having to deal with at home, and that another choice, that's what we're seeing, so I really do appreciate, I think these meetings and the information sharing is one way, but I think another way is the network, I'm going to tap into that database. I see Pastor James is on. I'm going to tap into that database that I just saw, because we have a referral network. I've been building it out with my own connections through the community board, but it's so much more that's just there that I could, that I have access to now. So I'm excited about that. So those are ways that this coalition is helping.
Thank you. I also want to open it out to our attendees and the rest of the Harlem Strong team. If you have any questions for the panel or for the speakers, this would be the time.
I do have a good morning, everyone. I do have a question for Dr. Reese. This is actually Dr. Mark's question. She had to jump off, but she wanted me to ask this. In lieu of the fact that New York City is banning the cell phones in a school, what effect do you foresee on the youth mental health? The phones are like a drug. Should we have weaned them off first? Also, the frustration with the youth comes from them not being heard. We always think of what we know, what's best for the youth, without asking them what they need.
It's powerful. It's a powerful question that states a powerful reality, right? And the powerful reality is that I'm dealing with all the time is that youth and young people have their own world. They have their own reality, and especially adolescents and young adults. And we treat them like they are small people in our world, when in reality, they have developed their own social systems, their own belief systems about it, about the way life works and the way the world works. Social media has only given them a greater platform to do that. A lot of people feel like the social networking, social media world has caused them to disengage from connectedness with people. There's some truth to that. But when the telephone was created in its general sense, it gave us the ability to connect with people in ways we were not able to. So though there's not face-to-face engagement, their engagement is still real. Mm-hmm. And that's why they respond to social media communication in ways that older individuals don't. Mm-hmm. It's because they are the generation that has grown up with this integrated into their normality, right? Mm-hmm. So their psychology is their normal sense of real reality is integrated around and in this as normal. Okay, so having said that, yes, there has to be zones of nurturing transitions with young people, because you're going to get backlash. And that backlash is not just young people being resistant, you are dismantling their world. Mm-hmm. Right? And so we have to figure out, how do we do this in healthy ways? Sometimes an adult perspective on a health strategy doesn't factor in, from an evidence-based principles point of view, the experience, competencies, and realities of the client. Mm-hmm. We just do it, because we feel like it's evidence-based and therefore this stuff works. Mm-hmm. But works for who? Under what context? Under what circumstance? Right? So part of this is we need bridges of communication with our young people that give them voice. It's part of the principles of youth development and youth empowerment that we give them voice, because we're supposed to nurture in them what they're going to need when they become secure, independent young adults. If we just take charge and move them around, when they hit their adult time where they don't have to listen, they're not listening. They're not listening. You gave me no voice before. Why are you going to give me voice now? Right? I don't have to listen to you because I've learned not to listen to you because you just took charge. You gave me no voice. Right? Even if giving them voice does not mean that you're going to make your judgment calls based on their perspective, as children, they at least have a voice. Right? And that encourages and nurtures in them inclusiveness. And that's what our young people are often seeking in social media, is inclusiveness in social engagement. It's not just social media. They talk to it. If you ever watch them connect with each other, they talk with each other, they relate with each other, they share with each other. And for them, that screen is face to face. Okay. For us, we don't conceive it that way.
All right.
But if you grow up in that, right, then that reality is just as real as, last thing I'll say, the social media world that ties to their phones is a world of business and entrepreneurship for young people now. You have young people that are millionaires from that world. So a lot of our young people don't want to go to college, don't want to go to vocational school. They want to be influencers.
That's true.
So when you pause, you have to pause and say, wait a minute, we are trying to dismantle a social cultural system that is embodied in this, not just take a phone. And that is where the illiteracy of adult decision-making is taking place. We just don't have enough accurate information. We have more ignorant, lack of knowledge information.
Wow.
Okay, hope that helps.
That's deep. Yes.
Can I make a
Thank you.
comment? Can I comment on just everything that just was at the question? I think it goes even deeper, right? So a lot of times we look at the issues and we don't look at the how this where it originated from, right? So I think that in our society there are so many systemic barriers and so like a lot of times folks are more reactive, right? The idea, I think, sometimes it's the system tells it's a system, right? So in an effort to fix the system, folks don't stop to think about what reaction this is going to have on the youth, right? And so I think we have to really, really look at our systems and look at ways how to mitigate the systems, right? Because if we don't fix the system, this is what we're going to continue to see, right? We're going to see reactive behaviors, right? And so therefore, the reactive behaviors are impacting the people, our youth, right? And this is going to continue, right? So it's almost like an open wound that is always a band-aid. Put a band-aid over it. Eventually, it's gonna get bigger, right? And so I think that's a real crisis in our communities today. I mean, you look at what's happening around us. I mean, all the different political, situations that are happening. And, one of the things that I was hearing this morning about, I'm listening to NPR News and they were like, okay, what are you talking about, when it comes to politics and, what voice do they have, right? And so you're right. Sometimes, older folks are because they're trying to protect and they think that's the best way to really, address an issue more so than to really look at to dive in to see what's actually happening. I'm a clinician and I work with youth, and so I talk a lot with youth around the same issue, not having a voice, and a lot of times when the voice is not there because parents are so afraid. They're afraid of what they're seeing around them. They're afraid that this is going to impact their kids. They themselves don't even know how to navigate the system. And so out of fear, a lot of times what they do is instead of trying to have a conversation around what's happening, they try to quiet their children. Yes, I'm not condoning what the behavior, but what I'm saying is that these are all systemic things that has to be dealt with. And unless we deal with these barriers in our communities, it's not going to change what we're seeing happening in our children. So,
Yeah.
I want to validate your point, but at the same time, it's deeper than what we're actually looking at.
Can I just throw something in that's just like 15 or so seconds? One of the issues that we face in what you just spoke about is that these systems have agendas connected to them. And when they have economic agendas, social agendas, cultural agendas, political agendas, when all of these different things have that, it really is not just the dismantling of the system. It really is how do we address those agendas, right? Because we often are dismantling the process that these agendas are using, and they just change process because the agendas still have power in the system. Okay, for example, the backdrop of all this social media stuff is economic development, right? Our young people are very out of touch with the fact that all these algorithms keep them busy, target them, focus on them for economic reasons. So the backdrop is you're a puppet to a system that you don't even realize you're being puppeted by, right? Because it's designed to make you feel like you have power.
Yeah.
It's
And
designed to make you feel like you have decision making, right? So part of this is educating our young people about what it is so that they have a broader perspective in their own decision making, right? One more little piece. We are really experiencing such a high level of reactivity because a lot of the systems that taught our young people self-regulation are dismantled. They are constantly challenged. So our young people are not developing the critical skills of self-management and self-regulation. So by the time they hit their adolescence and young adulthood, they are impulsive as anything.
Yeah. I have no
They are
control.
reactive as anything because they have not integrated the life skills of self-regulation. It's always go, move, and then after the fact. Go, move, after the fact. Instead of what's the forethought? Instead of no, you can't do whatever you want to do all the time. Slow that down, Johnny. Those things are challenged on so many levels, right? So though we're struggling with stuff, they're still growing, right? And there's an impact. So there are
Doc,
layers.
do you think we should be bracing ourselves to deal with the backlash of what is coming with the phone situation? And how that's something that we should be talking about. Then how do we do that? Or how do we integrate that as part of this particular, the bigger picture at this time?
It's
So we can get
scary.
ahead of it.
It's scary, but when we don't control the process that moves the process, we end up having to do interventions after the fact,
Yeah.
right? So part of this is what is that going to look like, right, for our young people when it starts? Because sometimes the systems are so active and engaged that we can only deal with it after the fact. We can't be as proactive as we want to because we don't have control over the processes. Right. So we have to prepare ourselves with what's that going to look like, right, when it comes, and are we ready to be available to the process? This sounds crazy, but sometimes, unless it's life threatening, we got to let a problem fail, social system wise, because the decision makers are not going to factor in our perspective in decision making, right? There are agendas. And I don't mean that as a constant negative. Some people really believe in their approach. And they have to learn from its failure, right? Instead of saying we're factoring in the voice of others that are well informed. I was just speaking to a person about treatment modalities and why our young people won't get services that are available. And sometimes it's because it's still wrapped up. This is just sometimes, not all the time, still wrapped up in old perspectives on mental health service. Sometimes wrapped up in old modalities, right? But you have young people that are engaging in creative modalities, right? Art therapy, music therapy, dance therapy, and so on, because the therapeutic side doesn't seem as obvious as talk therapy, right? They are able to make a navigation into a therapeutic creative mode that the therapist can navigate and they don't have to look stigmatized. They don't have to look like, oh, I'm getting mental health services. Oh, everybody thinks I'm crazy, right? So part of this is not just that we know these things are evidence-based and they work, but who do they work for? And how do we reduce the stigmatizations that come that stop them from accessing services of their own choosing, other than people forcing them into services?
Thank you so much.
I sincerely apologize for the paucity of time. We have to move to the next segment, but we'll stay back after 12. The Zoom link will be open, so please feel free to stay back and discuss more. This is very relevant and very needed discussion. As we move on to the next section, it's the coalition resources. We will have the Center for Comprehensive Health Practice present their resources to us. Vivian, if you want to go on to slide 35, that's CCHP. Yep.
Thank you. Hi again. My name is Jamie. I'm the Director of Behavioral Health and Addiction Services at CCHP. Like I said before, we are an integrated clinic in East Harlem. We offer many, many services, and we did receive a grant to expand our adolescent mental health services. So just a caveat to that, in order to receive any services at CCHP, such as mental health counseling, the groups, navigation, screenings, the individual does have to have primary care with us. And so once they establish CCHP as their primary care, they're able to access all of the different services. And so we do, I don't know if people are aware of it, but we utilize the social care network so we can identify different needs based on their social determinants of health. We can also involve the family in therapy, whether it's separate or if they want to have family counseling together. We also offer addiction treatment, and so we're expanding our training on treating adolescents and substance use, which is challenging, and there are not a lot of organizations that I think are offering that right now, and so we've definitely identified that need. And yeah, so if you have anyone that you want to refer, please send myself an email. I'm happy to provide you with the appropriate information and guide you to how to make an appointment. And that is it on my end. I don't know, Kanai, if you want to add anything.
Yes, my name is Kanai Wilkes. I'm the community engagement coordinator, and I just wanted to add that while I'm here, we're just looking to improve our visibility in the community. Some of the points that Richard made was amazing. I think that along with adding services for the youth, I think a lot of the things we're seeing today are rooted in detachment and distraction, and that's what leads to social media, high active engagement, and I think integrating more events and activities for the youth to do, such as art therapy, things that sway from the normal distractions, I think will help. So we're looking to involve ourselves in more community events if possible. So if you have any or you know of any, please feel free to email me at this email right here. But yeah, that's what I have for us.
Right. Thank you, Jamie. And we can move on to the Mayor's Office of the Community Mental Health, Lakeisha Grant.
Okay, sorry. I was taking a little while to come off mute. Good morning still, everyone. LaQuisha Grant. I'm the Deputy Executive Director for Mental Health Access at the Mayor's Office of Community Mental Health. And just a little bit about our office, if we can jump to the next slide. Perfect, thank you. So our office is a mayoral office, so we work across city agencies and work directly with both mental health and substance use providers across the city, as well as a host of other community-based organizations to really address the gaps and to reduce barriers to accessing mental health services for all New Yorkers. So we do not provide direct services, but we work very, very closely with a lot of community-based organizations, especially in Harlem, and again, with city agencies. So the services that I have mentioned here that I'd like to highlight are really city funded services that are available citywide for youth and young adults. We heard a bit about 988, so I won't talk too much about that. But again, we really see 988 as the front door to mental health services. You can call, text, or dial 988 or go to the website, which we saw, to get a whole directory of available mental health services across the city. And one option that I do like to talk about that's pretty relevant for young people who might be experiencing a mental health crisis is children's mobile crisis teams, and they can come out and respond within a couple of hours to a young person experiencing a crisis. I don't know if I know ABC is a coalition member here. They run the Children's Mental Health Crisis Teams for Manhattan. And so we're very fortunate to have that resource directly in our community here in Harlem. Teen Space is a telehealth option for teens here in New York. It's offered it's free of charge for youth, I think starting at age 13. DYCD, the Department for Youth and Community Development, has drop-in centers for what we call runaway unhoused youth. And I want to also highlight a resource that our office put together, and not just the resource, but really our office's website. I will drop a link in the chat to a webpage that Chrissy, who's on the line, who's joining us today, Chrissy from our team, developed a really great webpage with a ton of resources and more detail about specific mental health services that are available for people of all ages. But there is a resource in particular that you can find on that page that is specifically for youth. It includes all of the services that I just named, as well as other neighborhood specific services. And so we are here as a resource if you're ever looking for opportunities for partnership, or if you are looking to connect or identify other organizations within your community. You find a need and you have a need and you're amongst the people you're serving, and you want to identify partners. We're happy to help with that. We basically have a high level bird's eye view of the entire mental health system. And so I will stop there. Thank you for having me, and really great presentation from all of the presenters today. Lots of information. Thank you.
Thank you, Lakeisha. So on to Isaac.
Thank you. And thank you, Harlem Strong, and everybody for the presenters today. I think today was a very impactful day, and it was very timely, especially given just where our young people are at today. So just having these conversations are very, very important. I appreciate even the extended conversation as well. I think we would do well in these spaces as adults if we bring in some young people next time and have their perspectives in the room as well, because I think there's much to even learn from them in real time. Another choice youth and family outreach is the community outreach ministry for Mount Zion AME Church. We're located on 116th Street in Madison. I don't have any slides. I did drop a link in the chat. You can click on that link. I'm going to talk for just 1 minute about the Community Service Learning Initiative and the work that we do with young people. A lot of it is very specifically leadership and professional development, and we have recently started to use the 8 dimensions of wellness as a holistic model for really exploring professional development and holistic wellness with our young people. And the presenters said a lot of, they laid the good groundwork in stating that it's not just clinical, there's also these other sort of recreational supports in different areas of support that young people need. So aside from the support we encourage them to get, whether it be clinical or educational, we definitely offer some supplemental professional development support for them. And when we talk about the 8 dimensions of wellness, we're looking at with young people, emotional wellness, right? Learning self-awareness, coping mechanisms that I heard folks talking about, the resilience, the social wellness, building healthy relationships. And for a lot of our young people, a sense of belonging. And because they're in the phones because that's where they're finding their company. At the end of the day, we can critique it as much as we want, but until we create a better space for them to feel like they belong there, that's not where they're going to be at. Intellectual wellness, that critical thinking, that problem solving, the new skills, how do you leverage your wisdom, the physical wellness, the health, the fitness, the caring for their body. I don't think young people are stressed enough about how important it is for them to take care of their own physical health. Spiritual wellness, looking at helping them to look at purpose, values, some sort of connection to faith and community. Why are you here on earth other than just to live and die? So it's really important that we help young people kind of see a purpose and help them to see their worth, as young people. That occupational wellness, the career readiness, the visions for their future, their future envisioning rather, the environmental wellness, their connections to safety, healthy spaces. Also, what impact does the environment have on them, and how can they be a positive and or negative impact to the environment? Educating them about that, financial wellness, of course, financial literacy, budgeting, and entrepreneurship. So in our work with them, we hold them for at least 6 to 8 weeks through cohorts, and we bring in different speakers and different presenters, and we have a lot of different exercises and workshops to explore these different areas. And in that link, you can, look at some of the projects that they've created on their own. And I think like I would just end with saying, when young people are unsupported, when young people are unsupported, they often transition into young parents and still carry that trauma. And then it's just another cycle. A lot of I know for me specifically, I'll keep it on the eye. I have 5 children. My oldest is 24. I had the first one at 19. So, if I hadn't dealt with my trauma, then you can understand how dangerous it is for me to have a child. And we see this all the time. So if we're not really looking at, we have to support young people and really start also helping them to transition into this, life of multiplication. They're in relationship, they are doing things and they will multiply. And we want them to multiply blessings and not trauma, and that's everyone's responsibility, not just theirs. That's all of ours, because a lot of the trauma they get is from the adults. So I'm holding us more accountable than them. But yeah, I'll end there. But any information that you need from me, just reach out to me. Thank you for having me.
Thank you, Isaac. That was a wonderful set of resources. We really could speak about what they're doing all day, but we have to move on. So moving on to the next section, we have a number of events, but due to time, I'm not going into every one of them. But I just wanted to mention that we have an Everyday Health and Wellness series. It's a workshop led by Harlem Strong and resident physicians at Ryan Health. And that's going to be about various topics ranging from stress management, mindfulness to nutrition, and chronic disease prevention, and tools for everyday health. I also wanted to give a shout out to Housing Works. They are basically launching their behavioral health services for children. Vivian, can you move to the next slide, please? Sorry. Okay, they're starting their behavioral health services for children. So please reach out to us or Housing Works regarding this. But I'm going to skip the rest of the sections and move on to the coalition feedback survey. Please do go ahead and give your feedback on this and the coalition meeting, and also what you would like to hear from us. And finally, I pass it on to our key partner, our own Dr. Malcolm Punter, to give his final closing words.
Thank you, Dr. Sharma. Thank you, Dr. No, and all of the wonderful presentations and presenters this morning. I think we've learned a lot about how to engage with youth, where the gaps in our services lie with respect to youth, particularly school-age youth. I heard a lot of innovative information, and I think we have a lot of work to do and a lot of follow-up. So we'll be following up with all of you as a collective. And Dr. No, this coalition, every time we meet, it just inspires me even more. I think our work is unfinished, and we need to dig in. We're going to be the front line folks and service providers for the benefit of the next generation. We can't rely on politics. We can't rely on current leaders. There's a lack of leadership throughout the world, but we should be able to fill that gap in terms of leadership because we're closest to the young people. If they will trust anyone outside of their immediate generation, it has to be the people like us who have empathy, who understand, that they have a voice, who understand how to empower young people. And Harlem Congregations for Community Improvement was founded as a coalition on a coalition model. So we fit in my opinion, in any coalition, and we've always been on the innovative side of that process. HCCI in the 80s, first faith-based organization to have HIV and AIDS services for people in our community. We were certainly within the drug rehabilitation and treatment services early on. We had youth programs early on. We continue to do that. So we're happy to partner with all of you because everybody here has an impact, and we want to make sure we make the best impact as we dig in and insulate ourselves from the bad word to use, but from the insanity that we're seeing in our leadership. Thank you very much for coming out.
Thank you. Thank you all. It's just been an incredible discussion today. Thank you so much for sharing all your resources, your expertise. I think it's just incredible what local knowledge and resources we already have, and we want to make sure we showcase that as much as possible. And we know about each other's work and how we can support our community. So thank you so much. We will be putting together a grant to focus on youth mental health and, building off the Harlem Strong model. We're going to be, working to promote this specifically for youth and their families. So if you're interested, please reach out to us and let us know, and be part of the planning with us. Thank you. Okay. I don't know if folks want to stay on a little longer. I have to step out. I have another meeting that I'm late for, but I think the line will still stay open. And we hope you, are able to continue to network. Take care. Bye-bye.
Yeah, Ariane, that would be great to have another comedy show. Sure. We
Yeah.
enjoyed it.
I definitely want to talk to you guys about doing it and for 2026. So we could collaborate, but I want to get to do a big push so we can pack the house.
That would be great. We would love
Make a
that.
difference. Okay, great.
We'll
We
do
can
that.
circle back, Dr. Sharma. Just let me know when it's a good time to talk, okay?
Sure. Thank you. Thank you for, doing this every time. Amazing. Thanks.
Great.
Thank you.
Thank you very much, everyone. Have a good day.
Thank you for joining us. It's amazing.
Yes.
As I mentioned, it's a topic for a day, actually, to condense it and speak within 15 to 20 minutes was itself something amazing. Yeah.
Just wonderful. Thank you. Everyone enjoy the day, okay?
You too.
Bye-bye now.
Thank you. Likewise. Bye, everybody.
Okay. Are there any questions? Do we have any speakers? I don't think we have any more speakers. No. Okay. So Dr. Panto, do we have anything planned at HCCI, events for the holidays and things like that? I think you're muted.
On October 3rd, this Saturday, we have the Homebuyer Expo at the Riverside Church.
Oh, okay.
We know that, safety and security, housing is contributed to people's health and well-being, so health and physical. So we love everybody to come out, learn about how to, secure housing and affordable housing, as well as if you are ready or look to be ready in the next 5 years, how to prepare yourself to purchase a home, your first home.
Oh, wonderful. Do you have a flyer for that? Maybe we can put it in our.
I will. I'll email it to you.
Thank you.
Good.
Yeah, we can add that to the newsletter.
Excellent.
Yeah, so we've been, I don't know whether you had a chance to look at it. So Vivian has, on behalf of Harlem Strong, she's been creating and sending out bi-weekly newsletters. So we put in all the coalition information, flyers and things like that. So it can go out to the general population. So.
I love, yeah, I'll take a look, and if you
Mhm.
want it to me again,
Sure, sure.
see
I'll send you our past newsletter for you to look at. So, if you have any feedback on that, you can let us know too.
happy to do so.
We'll wait for a couple of minutes, right, Francesca?
Yeah, sure. If anyone has any questions.
Mhm.
Thank you for the conversations today. It was really very enlightening. I did want to find out when we received I apologize, I'm putting on camera. Hi, this is Michelle. When we receive the slides, will we also receive everyone's contact information to?
So yeah, we integrate everything into the report.
Okay.
So you'll have the attendees, and we'll make sure that their contact or the email or whatever they give us is there in that.
Okay, thank you. And the statistics, because wanted to connect with some of the information that we got. And thank you so much. It was absolutely wonderful.
Appreciate it. Thank you. Let us know if you have any other topics of interest for the future coalition meetings. So this is our 8th meeting, so we've covered all the important topics so far, but we do have a couple more. But anything of interest to our coalition will be a great thing for us to think about.
Well, there is one that I'd actually like to do. That's something that I've been working with towards men. So I'll reach out to you and to do that. And especially as we're coming on to the end of the year, to really look at the intensity of depression and grief during the end of the year and how to really cope with it, especially around holidays. The incidence of suicidal ideation as well as suicide during that time, and how many people go into deep depression, as well as how many elders are hospitalized because they don't have family members to go to.
Oh, right. Okay.
Yeah.
That would be, yeah, that's a niche topic. I mean, but so relevant.
Yes. Okay. So thank you so much again.
You're welcome. Thank you.
Take-
You too. Okay, it's 12:15. So thank you again, everyone, for attending. We'll make sure to compile everything into from the slides into the report and send it back to all of you. Thank you once again, and hope to see you all in our 9th coalition meeting. Bye.
Thank you, everyone.
Hey, it was great. I'm sorry for the technical hiccups.
No, you were fine. I mean,
Dang. Okay.
No, it wasn't. I'm sure it
Yeah,
felt more
I was
stressful than
like,
it actually was.
yeah, it was definitely stressful on my end. Like I was trying to share Dr. Aurora's slides, and every time I tried to hit the presenter mode, it wouldn't let me just present. It kept doing the presenter view, and I was like, it was just taking up both my screens, and I wasn't able to find like where to share the screen. So it was just a little bit hectic, and I think
Her slides were, I think her slides were like formatted weirdly anyway, because I couldn't get them. I think it was like she saved them in a specific format because I couldn't get them to like integrate into the other slides
hmm
without all the
hmm
formatting going crazy. And normally I have some issues, but normally it works out. So
Yeah, yeah.
I think there was just like it was something to do with how she had saved them, maybe was the issue.
Okay. Yeah, because I kept clicking play from start and it just kept going into presenter view and then I could not share my screen. I couldn't find the Zoom application to share. But regardless, I think it went well. For the report, I already have the draft template ready to go. So I'll go ahead and get started on that. And I maybe we can try to push and I can try to push to get this completed by Friday and maybe send it out first thing Monday.
Oh, that'll be perfect. Regarding Dr. Gopalan's, did she have many slides or something?
Uh Wait, who? Which one?
The third, was it, she was the third, yeah,
Oh, the
third
one
speaker.
she presented her own slides, right?
Yeah, yeah. Because that, I thought it went very long, didn't it? I mean, more than,
Yeah, it did. She did have a lot of slides because I was like looking at the kind of progression of her slides kind of on my end. There were so many left, and I was like, oh, long
yeah.
presentation.
It's such a race at the end, and I hate cutting off people. It's I know,
Yeah.
Francesca, you are like, cut it off and get it. I was like, are you going to give me a pause so I can cut it?
Yeah, it's so hard.
It
I
just
mean,
sounds
I
rude. I mean,
have
it's
we, yeah, have we ever considered extending it? I know that 2 hours, it sounds long when we send out the invitations, but in real time, 2 hours goes by so fast, especially when conversations are so great. And I feel like so many people had things to share and things to say. And so just out of curiosity, if we've ever considered doing longer than 2 hours.
I asked Vicky, she straight said no.
Oh, okay.
So I mean,
Yeah.
it's every time this happens, like, we don't get to present the events. The only reason I initially thought we'll just skip the entire section, but I know Ryan Health had actually hopped in because we are doing this series with them. And we had a call with them. We told that we'll speak about it today, as well as housing works. We are going to make them our next gateway site kind of thing, not gateway site, our partner to work. And they wanted this to be spoken about during the meeting. So that's the reason I thought,
hmm
okay, let's at least present these two. Because,
Yeah, yeah.
and
And maybe if we can't extend the time, maybe consider, because obviously I know that, we want to be able to bring in so many perspectives and expertise from different parts of the framework and the topic at hand, but maybe consider cutting back some people, maybe less presenters, so that there is more time for them to have questions and be able to answer questions and whatnot.
yeah, that can be done, I guess. Yeah, maybe only two presenters. That should be
Mm-hmm.
better. Yeah, it always increases at the end.
Yeah.
Yeah, Francesca, you want to ask Vicky about having it for 2 hours, 30 minutes or something? the next UN meeting you go to, you could possibly, ask her, can we make it 30 minutes more?
I'll give it a go. I don't think I'll get any further than you, but
Let's see. But yeah, point taken, Vivian. We definitely need to cut this short. It's giving me palpitations at the end. But yeah. I've told Francesca, I'm very particular about time for me, to the extent these days I don't even speak out of my mind. I write it down, I type it down and then speak, so I don't speak extra. So it's just becoming difficult to control the time. And there have been people who've given comments like, stick to the time. And, it's initially that it was poorly organized because we're changing things and all that stuff. But I want this to be a little more structured and, it shouldn't look like we're running every time, once or twice, it's fine. It can't be that.
Yeah, definitely. And I think I wonder like how much time is put into kind of prepping the speakers, because I know that you both have coordinate that communication with them, and I just wonder if they are aware of how much time they have, and just kind of reminding them to maybe practice, just because we are on such a tight schedule, and just to be, not that they're being disrespectful, but just to be more considerate of the time that they're using up in the meeting, to share that space for others. And so maybe just having more of those conversations with our future speakers in the future.
Yeah, we do warn them, but I think even being like just saying like we're gonna let them know before as another reason to bring up the limited time that they have, like when they join, be like, we will send you a warning in the chat when you're like 3 minutes away from your time.
Yeah.
So it's like,
and
even if
it's
they
also
don't see
hard
it's just
to
telling them.
right. And it is hard too, because while they're presenting, they're really just focused and fixated on the topic at hand. They're in deep thought, and so the last thing I think they do is check the chat to see a warning for time. So
yeah, and we also sometimes, like when Vicky speaks, it goes 10-15 minutes over time. So, that's also a place where we cannot. But I think
there is a thing, I think, that some folks use this application that kind of presents a timer within the meeting. And so they actually see that time presented, kind of like a countdown. I don't know if that's like a little bit too much pressure or constraining on them, but something that we can consider using, because I think it's built into Zoom as well, the application.
Sure. I mean, that would be great. But yeah, all these things for the next one. So next one should be when? January, maybe? Yeah.
Yay.
Next year we'll think about it. Okay.
Yeah, so I'll go ahead and I'll start formatting the coalition report. I'll also be adding the video and just everything that was talked about today. And if y'all receive any additional information or resources from the speakers or presenters, if you could forward them to me, and I'll make sure it's included into the report.
Sure. Wonderful. Thank you again. All right.
All right, sounds good. Thanks both.
Thank you. Bye.
Bye.